All right, so we're going to get started. Thank you very much for joining. Today's Grand Rounds is focused on prevention and the preventive cardiology, or in general, prevention of risk factors in cardiovascular disease spectrum and cluster of disorders is a very important area of investment, research, and interest to the entire health community. And certainly for us here, it gives us a great opportunity to bring in some of the national experts and also our panelists today. But before going to our experts and panelists for today's presentation, I'm going to quickly share the screen to take you through our Grand Rounds CME and MOC assignment. So with that, if I would just change the display setting, you'll have the recording of the current video for the presentation at the website of the division. You can always feel free to go back and use the presentation to answer your questions that will feature either during your CME crediting session time frame or in the MOC. For the CME credits for this session, please feel free to text now the number 20406 to the number 888-816-4893 within the 12 hours as an SMS message with an active profile in the Rutgers CME cloud. And please use your mobile phone field given in the profile. And if you're a physician who would like to get an MOC credit as well, the first step would need to be completed. And then you'll have this link, which will be again displayed back in the chat box. So you can copy and paste it, or you can use this particular barcode to directly log in to the website where the room code is Future 2024. That will take you to sets of questions. And if you get them right, your ABIM MOC points will directly be linked in. So with that, it's my great pleasure today to bring in our experts for the session. And our Grand Round presenter is Dr. Andrew Moran. Dr. Moran is Associate Professor of Medicine, Division of General Internal Medicine at Columbia University Irving Medical Center and Chief of Global Hypertension Services. I was just briefly going through his profile, and what was very striking was his immense undertakings in epidemiology, decision analysis, comparative effectiveness research, where he was trained at University of California at San Francisco and Columbia University and University of New York. And he has specific interest in cardiovascular disease epidemiology, decision analysis research with a focus on highest value approaches to cardiovascular disease prevention and treatment in US and abroad. He has a track record of uninterrupted AHA and NHLBI funding for the last 15 years to support his research with national leaderships in several areas of cardiovascular diseases, epidemiology, health service, research and cost-effectiveness analysis. Some of the position and appointment which are really important and very impressive, to be honest, include his role as the deputy editor of the Global Heart. I was weekly associated with the journal long time back when it got initiated at Mount Sinai Medical Center. And subsequently, of course, he assumed the role as the deputy editor. He also is a current appointee to the New York Department of State Health Advisory Panel on Implementation of Hypertension Control Programs. And he's the director of the Global Hypertension Control, Resolve to Save Lives, an initiative of vital strategies in New York, and guideline development group member for the WHO 2021 Global Guidelines on Treatment of Hypertension. He has over 170 peer-reviewed publications and several NHLBI grants that are focused on the implementation science of preventive cardiology, and including decision support services, health economics, medical and policy decision analysis. With that, I'm going to welcome Dr. Moran. Andrew, welcome.
Thank you so much. Thank you for that warm welcome.
Yes, and I'm also very excited to bring on our panel of experts, which includes Dr. Ethan Ham, Professor of Medicine, inaugural Vice Chancellor for Population and Health at Rutgers Biomedical Health Sciences, and core member of the Institute of Health Policy care policy and aging research, and he's implementing really a very transformative trend of how population health preventive services across spectrum of cardiovascular and metabolic diseases using a combination of primary care to a full spectrum advanced cardiovascular diseases specialist could be utilized. So we are looking forward to a lot of work in the future, and I think that makes it very exciting because Dr. Moran's presentation is going to basically take us to the next level of panel discussion, and maybe we'll have some interesting conversation of how we can have Dr. Ham help us not get to the forefront or the doors of Dr. Vagenescu, or only go to Dr. Vagenescu in a preventative fashion, in a way where you can be calculative and predictive rather than reactive. So Dr. Vagenescu is our cath lab director, and he's interested beyond the coronary intervention to also think about advanced services like the hypertension, renal denervation therapy, and it's very complicated. But I think it's going to be interesting to get this panel to discuss at the end. But now I will bring Dr. Moran to give his talk on lipids and how taking care of lipids early on could prevent future catastrophes.
Thank you so much, Dr. Sengupta. So I'm going to share my screen and start my presentation and look forward to the discussion and feedback afterwards. So the title of the talk is Value of Early Lipid-Lowering Interventions to Prevent Later Life Cardiovascular Disease. And as Dr. Sengupta said, I'm Andrew Moran. I'm the Associate Professor of Medicine at Columbia University. And I'm going to briefly introduce myself and my research team, talk to you about what we call the Young Adults Study, which is a completed study, and then talk about a current project, which is focused on familial hypercholesterolemia screening, especially in children. And I want to mention I have no conflicts of interest disclosed related to this talk. So in terms of an introduction, so my group at Columbia University includes me. I'm a general internal medicine primary care physician. In terms of my clinical work, that I focus on cardiovascular disease prevention in terms of research. The research team includes expertise in clinical medicine, epidemiology, decision analysis, and health economics. So we have team members who bring expertise from a lot of different disciplines. Our research themes are planning and evaluation of hypertension control programs, including guideline evaluation and analysis of clinical trials, for example, SPRINT and the LA Barber trial and others. And we also are assessing the value of early cardiovascular disease prevention, which is the topic of today's talk. So we're going to talk about epidemiologic model development and prevention policy simulations. So to start with the completed young adults study, I'm going to give you a few background slides to orient you. This one is, you've probably seen this or heard about this before, but it's basically, it's a graphic depicting the hierarchy of medical evidence or public health evidence. And at the top, we have the randomized controlled trials and then the studies that distill that evidence across many trials, including systematic reviews and meta-analysis. And so usually any kind of health policy, clinical guidelines, and even our day-to-day decisions should be driven by this kind of high quality evidence whenever possible. However, there are limitations of randomized, traditional randomized clinical trials. They can be expensive. And we're seeing that there are fewer and fewer of these kind of trials, at least NIH funded, like SPRINT or ALLHAD, because of the complexity and the expense. These trials typically last 3 to 5 years in duration, partly due to that expense and complexity. And they may not align with patient or payer values, which are focused on gaining a longer, healthier life. And it can be challenging to study treatment effects in younger people with that kind of time horizon. Given that time horizon, usually trials will select a short, high-risk group because they need to make sure that there'll be enough clinical events within that short time frame. And there can be selection bias in terms of who's included in the trial. And then again, for efficiency, many trials use combined clinical outcomes, which may be difficult to interpret in terms of what's meaningful to patients. So there are some studies or some methods that have approached more of a longer term perspective. One of the limitations that I told you about in the prior slide. And this slide shows you some examples of short-term clinical trials that actually were able to do long-term follow-up. And the examples I list in this slide are the SHEP, systolic hypertension intervention trial in older adults in the 1990s, WASCOPS and ASCOT, which were both statin treatment trials. And they all had, typical of most treatment trials, they had a follow-up time of less than 5 years, but they were able to follow these patients up for a longer term. You see on the right is an illustration of follow-up in the ASCOT legacy study for 16 years. And you can see this is really where, if you've ever heard the term legacy effect, this is from this kind of study, which shows that the separation between the placebo and the statin treated group persisted for years after the study intervention. So this is what we call a legacy effect. Well, in terms of the kind of work that I often do, health economic analysis, this is actually the standard to take this kind of long-term perspective in terms of evaluating the value of treatments. Health economic evaluation usually gathers total costs and total health gain. And in terms of measuring health outcomes are usually quantified as life years or quality adjusted life years. And often a long-term perspective, either lifetime or 10, 20-year perspective is the standard for this kind of analysis. And the reason is that a lifetime horizon is actually more meaningful for healthcare payers who might, not so typical in the US, but let's say for Medicare, you're going to be responsible for this individual for decades of life, right? And if you're a patient or an individual that's seeking healthcare, you're probably interested in the longest, healthiest life possible, not just what's going to happen over the next 5 years. So this is why health economic analysis usually does use this longer term perspective. So there are some ways outside of the traditional clinical trial approach at really getting at what long-term exposures and outcomes mean, and we can even do this in a randomized way. And a great example of this is what's called a Mendelian randomization study. And basically, we're taking people who have a genetically determined effect on their physiology and seeing how that plays out over many years' time. And so there's some great studies by a group in the UK led by Brian Ferentz. And this graphic here is showing a summary of a number of these Mendelian randomization studies with a genetically determined lower LDL cholesterol, comparing it with statin trials. And what they did in this analysis that you see, it's actually on the far left, there's a list of the unit change in lower LDL cholesterol. That's been standardized. So whether it's the statin trial or the genetic studies, they're all standardized to the same reduction in LDL cholesterol compared with either the wild type gene or the placebo in the case of the statin trial. So it's the same degree of LDL change, but you can see that the risk reduction in terms of coronary heart disease is many-fold greater in the genetic studies. So why is that? The same amount of change, but much greater effect. And what we think is, the reason is that people who have a genetic variant that gives them a low LDL cholesterol, it starts at birth, right? This is a lower exposure they have for their entire life versus a statin, which you might start at age 40 or 50. So it's really about the cumulative exposure to LDL cholesterol. And you can think of it sort of like pack years of tobacco, if you're familiar with that concept. So a lot of this background goes into what we call the young adult study. This is an NHLBI funded study, and the premise was that strong epidemiologic evidence demonstrates that cumulative risk factor exposure starting in childhood contribute to the evolution of atherosclerosis and later life atherosclerotic cardiovascular disease. Most clinical trials last about 5 years or less and enroll older high-risk adults. Cumulative risk factor exposures are not accounted for in treatment guidelines. And so our assumption is that we can use mathematical models to translate observational evidence into simulated long-term treatment trials. So the main aims of this study were to estimate potential life years gained from blood pressure and LDL cholesterol control during young adulthood. In other words, early prevention, accounting for cumulative atherosclerotic damage from young adult exposures, and then taking that epidemiologic observational data and results, project life years gained and lifetime cost effectiveness of early treatment of young adult raised blood pressure and LDL cholesterol. And as you're going to see, we really drilled down a lot more into LDL cholesterol. We can talk about that later, but I think it'll become apparent why. So our first aim, this is really our epidemiologic study aim, looking at the independent contribution of young adult LDL cholesterol and other risk factor exposures to later life ASCVD risk. So for this study, we pooled observational cohorts. We have 6 cohorts, a total of over 36,000 unique individuals. And you can see these are some of, if you're in the cardiovascular disease field, you'll be familiar with a lot of these cohorts, including the Framingham offspring study and others. But why do we of course needed the big numbers, but we also needed to take this lifetime perspective. We needed to pool a lot of different cohorts to cover the entire adult age range. And so you can see the sampling density on the right and the age distribution or the distribution of study visits over these different cohorts. Now, the Framingham offspring study was great because it had people who were enrolled at young adulthood and followed to older age, but that's actually kind of quite unusual. Most of these cohorts had a limited part of the lifespan where they observed people. So we pooled all these cohorts together, and this is how it all came together. So you can see on the left panel the study design in terms of the number of participants, the numbers of cardiovascular events that were gathered by these studies. And what we did was use mixed models to estimate an exposure trajectory or history for every individual in this cohort, regardless of what age they entered. And just to illustrate what this looks like, in the bottom right of this slide, you see a figure showing LDL cholesterol on the y-axis and age on the x-axis. And the orange dots are the actual observed LDL cholesterol in this particular individual, I think maybe from the ERIC study, I can't remember, but this individual had these measurements, and you can see that there was a time point around age 60 when this person was starting the statin and their LDL cholesterol went significantly lower. And so the solid blue line is the line describing estimating their lifetime trajectory of LDL cholesterol. And then you see there's a dotted line on the left, and that's showing the time-weighted average exposure to LDL cholesterol during young adulthood. And then the dotted line off to the right is showing the time-weighted average cholesterol at age 40 and older. And so what did we find? We looked at a variety of different outcomes, and we looked at blood pressure and LDL cholesterol exposures. And just to hone in on the LDL results, this is really where our results popped, and we saw a very clear signal. And so I'm just going to go to the next slide where we summarize our findings for LDL cholesterol. When young adult and later, so one thing I didn't mention is that when you see these forest plots and these effect sizes, this is the young adult exposure, the time-weighted average with their later life exposures in the same model. So this is an independent effect of what's going on when you're a young adult on your later life risk. So when young and later adult LDL cholesterol were considered jointly, an LDL cholesterol of 100 milligrams per deciliter or greater compared with less than 100 was associated with a 64% increased risk for coronary heart disease, independent of later adult exposures. And so this is really an independent effect of your young adult cholesterol history. And it's also, we saw a dose response effect. So step 2 here is estimating cost effectiveness of initiating lipid lowering therapy in young adults with raised LDL cholesterol. So here we translated these observational study results into these simulated long-term treatment trials. And we used this mathematical model called the CVD policy model. It was developed by my mentor, Lee Goldman, starting in the 1980s. We've updated and refined the model many times over the years, but it's a really tried and true model. And you can see in this schematic, we gather a cohort of individuals. Usually we sample them from the US NHANES survey, so the national representative cohort, and then we put them into this model where we simulate their outcomes, cardiovascular disease, including stroke, coronary heart disease, and non-cardiovascular death. And this model cycles year to year, and we follow individuals in the model. And then over time, we count up the cost, both the cost of treating people with any kind of intervention, but also the cost saved from avoiding any cardiovascular disease events you might have avoided. And we also count up life years and quality adjusted life years. So this is getting into some of the guts of this mathematical model. It's a micro simulation model. That means we simulate individual people going through from year to year. It's nationally representative. And the key thing for this research is that we developed a prediction model of ASCVD events that included the time-weighted average cholesterol. And we also had models with time-weighted average blood pressure, but this is a cholesterol-focused study. So we had time-weighted average cholesterol from age 18 to 39, and then time-weighted average cholesterol from age 40 and above. And this is from our main paper reporting on the cost effectiveness study. And this gives you a conceptual model of how this all works. So basically on the left panel, let's say we take an individual and we're simulating their life history. This person, you can see that about age 20, they have an LDL cholesterol that's quite high. It's 175 milligrams per deciliter. Now, without intervention, this person's cholesterol would be maintained at that high level until age 65. Now, if we were to treat them, let's say typical screening, we screen people usually for cholesterol around age 40, and this high cholesterol is found, and they get put on a statin. And that's the green dotted line. You can see now the LDL cholesterol has been reduced during midlife and older. And then there's the third scenario, which is the purple line, where there was an earlier screening. The person's LDL cholesterol was reduced at age 20, and they have a lower cholesterol from age 20 to 65. And in this, when we simulate this hypothetical situation, you can see the results in the right-hand panel. So the bars are showing the number of ASCVD events, and the black line is showing the average number of ASCVD-free years. And you can see that compared with no treatment, certainly there's a benefit to later life initiation around age 40 of a statin, but a much greater benefit if the lipid lowering is commenced during young adulthood in this person. So in terms of our lipid lowering strategies that we used in the cost effectiveness analysis, we had standard care, which is per the ACC/AHA 2018 lipid guidelines, statin treatment for adults age 40 and above based on their cholesterol level, ASCVD risk, diabetes, and all young adults with LDL cholesterol 190 milligrams per deciliter above were clearly indicated for statin in the 2018 guidelines. So please write this down if you're going to take the CME, because this is one of the questions. Statin strategies. So these are these hypothetical strategies for treating young adults. We had a couple of scenarios only treating young adults with an LDL cholesterol 160 milligrams per deciliter above, or 130 or above. And we looked at two different pricing scenarios, the average US price and also the Medicaid generic price, which is a good deal lower. We also compared this to US Preventive Services Task Force endorsed lifestyle modification strategies for these same LDL cholesterol groups. And of note, after any of the simulated individuals in the model reached age 40, they would be treated according to the ACC/AHA guideline. So to make sure you trust this model, we did have to do some validation. To start with, the US cohort incidence of ASCVD and mortality rate were validated using contemporary national life tables. And we also performed a benchmarking exercise. Now, if you go back to, if you remember the slide I showed you about Mendelian randomization studies, you remember that there was this greater effect size for people who had those LDL cholesterol lowering variants compared with people with wild type. And so what we did was we had a base case of outcomes with people with untreated LDL cholesterol. And then we had a simulation of lowering LDL lowering from age 20, from birth, which has come from the literature based on PCSK9 loss of function mutation. And so that's the relative risk you see there of 0.78. And then we had a simulation using a moderate intensity statin starting at age 18. So this is young adult treatment. You can see the effect size is 0.86. And then you can see starting a statin, moderate intensity statin starting at age 40. So this is middle-age treatment. And again, the same lipid lowering amount, but the effect size is about 0.92. And so we don't know exactly the effect size of if what we're simulating for young adults would be reproduced if you actually performed a clinical trial and starting statins at age 18. But we know that it's plausible that the effect size is between later life statin treatment and lifelong lower LDL related to a genetic variant. So now getting to our main results. So if you're not familiar with cost effectiveness analysis, I'll orient you a bit. What you're looking at in this figure is called the cost effectiveness plane. On the y-axis, we have increasing costs, and on the x, as we go as we go upward, and on the x-axis, as we go left to right, you have increased QALYs. So moving left to right on the x-axis, you're getting more health, and moving up the y-axis, you're getting greater costs. So the optimal interventions that we would want are very shallow slope. So moving from left to right, but keeping things low on the y-axis. Those are the highest value things. And you can see that there's a cost effectiveness threshold for what's considered intermediate value. That's the upper dashed line. And then very high value is the lower dashed line. So starting with young adult women, if we take the young adult women and treat those who have LDL cholesterol of 160 or above, statin treatment is intermediately cost effective. That's point B that shows up on the graph on the lower left. And then if we were to go further and add more patients so that we get those who have LDL cholesterol 130 or above, that would also be intermediately cost effective. You can see the ratio is $123,000 per quality gain, so it's certainly on the borderline of something that you might be willing to pay for. Treatment or not, borderline cost effectiveness at non-generic prices, but what you're looking at here are the generic prices. And the other thing to mention is that I didn't talk about points A and C. Those are actually the lifestyle management scenarios, and those were dominated by statin treatment. And so we shift now to looking at the results in young adult men. Same orientation for this figure, but you can see that for young adult men, whether it's starting with LDL cholesterol 160 or greater than or equal to 130, points B and D are very much below the lower line, showing that they're highly cost effective. And in fact, the ratio for 160 and above is $4,000 per quality gained, which is getting close to cost neutral. So it appears to be quite high value. And again, the lifestyle approaches were dominated by the statin treatment. So the conclusions in terms of the young adult study are that lacking clinical trial evidence, simulating decades-long trials as a feasible approach to estimating the effectiveness and cost effectiveness of long-term statin treatment in young adults with raised LDL cholesterol. Based on our results, we have the most confidence in recommending early statin treatment for young adult men with LDL cholesterol greater than or equal to 160 milligrams per deciliter. And in the US, initiating statin treatment in young adult men with raised LDL cholesterol is highly cost effective at generic drug prices. But it's also worth mentioning that in terms of these lifestyle interventions that we use for comparison, these are individual counseling, behavioral counseling in a primary care setting. That's where what these studies did. And we didn't include something which is shown to be very effective at the population level, which are population-wide programs. And the most classic of those is called the North Karelia study in Finland, which have been highly effective and saved many lives. So just to say that behavioral change and lifestyle change is not, we didn't give it a fair assessment. We just use a particular kind that's quite expensive. Okay, so we're going to shift to talking about ongoing research. So the question is, what's next for my research team in terms of early CVD prevention? So what we're currently working on is another NHLBI R01. It's the childhood FH screening study. And the question it's asking is, what's the optimal age and approach for screening children from familial hypercholesterolemia? And if you're not familiar with familial hypercholesterolemia, you'll hear more about it in the subsequent slides. But it's basically one of the most common genetically determined disorders in our country, along with the BRCA mutation that affects breast cancer risk, and Lynch syndrome, which affects colon cancer risk and other cancers in families. These three conditions are chosen because they're relatively common. Familial hypercholesterolemia occurs in about one in 250 people, and they also have severe consequences if left untreated. So for this study, we added to the pool cohorts that I showed you before, the adult cohorts, this International Childhood Cohort Collaborative. It's over 18,000 kids who are enrolled and followed for many years for their risk factor information and cardiovascular outcomes. We also linked our adult pool cohorts to the TopMed genetic data resource from the NHLBI, so that we could characterize which of the individuals in our pool cohorts had known FH genetic variants. So Also in the background around this, so these are some of the main colleagues I've been working with, including Sarah De Ferranti. She's a pediatric cardiologist at Boston Children's Hospital, and she's the main collaborator for this study. And we were able to weigh in about last year when the U.S. Preventive Services Task Force made a statement about childhood lipid screening, and essentially they issued an I statement, which means insufficient evidence. And our editorial in JAMA, we really came out to say that the focus really should be on the familial hypercholesterolemia, which is, if it's left untreated in childhood, can lead to having myocardial infarction or ASCVD in people's 30s and 40s if left unrecognized and untreated. And so we really think that screening for FH, it should be the main driver to motivate screening for lipid disorders in kids. So I'm going to show you just some of the results that we've generated so far from our study. As you saw in the previous young adult study, we spent a lot of time on the epidemiologic data analysis and gathering the evidence on effect sizes and other details, and then we move into the simulation modeling phase. So this, I'm going to show you some results from the observational data analysis. And so this study was published in Circulation, and it's showing that, and there was another study related to this published in the JAC as well. But basically, what these results are showing, if you look at the forest plot on the right, for individuals who have, it's not surprising if they have a very high FH range LDL cholesterol of 190 milligrams per deciliter or above, that they have a very high risk of ASCVD compared with those who have lower LDL cholesterol. But what's interesting in these results is that the contribution of having an FH genetic mutation, so the genotype on top of phenotype, and even if a person has an LDL cholesterol that's below 190, a lot of these people have an LDL cholesterol more in the range of 130 to 189, those people have a higher risk than people with very high LDL cholesterol above 190, but without the genetic mutation. So clearly the genetic mutation has a very strong contribution to risk. And again, we think that this is because of what we alluded to earlier in looking at those Mendelian randomization studies, that these are people who certainly have had a lifetime of high exposure to LDL cholesterol. And it's not that their cholesterol rose as they had environmental exposures and lifestyle choices that led to their high LDL cholesterol. And to illustrate that, we have on the left-hand side a part of this analysis where we took people in the data set who had basically a similar LDL cholesterol around the age of 60. So you can see the red line and the blue line kind of converge around age 60. But when we look back to their prior exposure history, those who had an FH mutation, those ones in red, they had high LDL cholesterol exposure for several decades of life, versus the people without the genetic disorder who sort of rose over time to reach their age 60 level. And I'm going to show you some data that when the analysis where we pooled the childhood cohorts with the adult cohorts, and again, we're able to fit these lifetime trajectories of LDL cholesterol history over the entire life course. And you can see here that this is sort of what you would expect, that LDL cholesterol rises over time from childhood to adulthood, although we purposely left out the ages around puberty when the LDL cholesterol actually dives briefly. But other than that, it's a pretty smooth line of increase. And in this paper, we make the point that it probably makes sense to use a percentile approach when determining what is a very high cholesterol and what might lead to an evaluation for FH in childhood, because currently there's a cutoff of 160 milligrams per deciliter for all children, but really using a percentile approach, which is what they use for BMI and determination of obesity, and also for blood pressure abnormalities, would probably make more sense for children. So this is going to be important as we go to our screening simulations. And I just want to mention, this is not my research, but another important piece of evidence fell into place. It was also based on this I3C child cohorts data set. And this was just recently, maybe a week or two ago, published in the JAMA. And it's showing that children, this is about 5,000 children pooled from 6 prospective cohort studies. And it showed that individuals who started with high non-HDL cholesterol in childhood, but they resolved to a normal level, they ended up having the same cardiovascular risk as people who maintained a normal cholesterol for their entire life. So this is a really meaningful result in terms of prevention, that it shows there is this opportunity, if you're able to lower cholesterol during childhood, to basically take someone with high cholesterol and high risk and make them through lowering their cholesterol, give them the same risk as someone who has had a normal cholesterol their whole life. And so we're now moving into the phase of designing different FH screening strategies. And you can see this is a schematic showing there are a number of different options we're going to look at. You can use a cholesterol threshold alone. You can factor in family history of early atherosclerotic disease. You can combine genetic testing after family history, or you could go directly to genetic testing after the lipid testing. So these are all going to be tested in our simulation study. Now, at the same time, Sarah and I we're starting to talk about a clinical trial of FH screening. I know I talked about this with a couple of people at Rutgers when I visited recently, and it's very tricky. And we've been working with our stakeholder panel of general pediatricians and pediatric cardiologists. And we also have on our stakeholder panel a mother of a child who has familial hypercholesterolemia. And so we're getting different perspectives on how you go about designing a study that would, a trial that would answer some of the questions that have been vexing the Preventive Services Task Force on this question. So I'm just going to read some of the feedback we've been getting from our stakeholder panel about a trial of FH screening in general pediatric practices. So regarding pediatricians, a pediatrician said that you need to get pediatricians on board and mindful of long-term consequences. Leverage things they're familiar with, like adult consequences of childhood obesity. Another pediatrician was concerned about genetic testing and statin hesitancy in the setting of the anti-vaccination culture that's pretty prevalent in the wake of the COVID-19 epidemic. From a pediatrician health system medical director, blood draws in kids are a tough sell. Use sites, clinical sites that already have point of care testing. Do we know if having point of care testing increases screening rates? We need to check that. We need to look at the data from these populations. And a disparities researcher said you need to design an intervention or design a screening approach that will decrease and not widen health equity gaps. So the next steps for this work, we're putting in a new renewal application of our current R01, looking at several aims, benefits, potential risks, and costs of novel lipid-lowering therapies, and even gene therapy for FH, which is something that is very close to being made available. In aim 2, we're looking using qualitative research to develop a pediatric FH patient and family shared decision-making algorithm around genetic testing and treatment options. And aim 3 is using our simulations to design a clinical trial in a much more nitty-gritty way than the rough schematic that I showed you, but including some of the information we're gathering about implementation barriers during our AIM-2 qualitative research. And last slide, before we go to the panel and the discussion, this is idea about a protocol for FH screening. And it'd be great to get your feedback on it because this is in development. So our idea is that you start in general pediatrics practice, you have a clinic visit. This is between ages 9 and 11. This is the age when screening is supposed to be occurring, but in fact, only 3 to 10% of kids get their cholesterol checked. So they're supposed to get their cholesterol checked. So you do informed consent. You do point of care LDL cholesterol check, and you also do a buccal swab in case needed for genetic testing. Now, the kids who have very high cholesterol, you send that genetic test off to the lab, and you have a service, a telemedicine service that does genetic counseling by video visit and counsels the family. And then the family returns to the primary pediatric practice for a visit for shared decision-making about what to do about that new diagnosis. And then use the EMR to follow up LDL cholesterol, dietitian referral, or a new statin prescription in the EHR. So it's a very rough work in progress, but that's kind of where we're heading. And I'm hoping in this talk, I kind of gave you a sense of an arc of research starting from some basic questions about is earlier better than later, and how that translated into a study in young adults, and then going earlier to the potential prevention in childhood, and then hopefully translating this into the kind of studies that might change practice, or at least the U.S. Preventive Services Task Force recommendations. So with that, I'd like to thank you, and I want to acknowledge my core team, Yi Zhang, Brandon Bellows, and Kieran Coley-Lynch, who really made this research possible.
Thank you very much, Dr. Moran. That was excellent, and I think it brings into perspective. And I think we're going to invite our panelists also. And I'm going to just get started. I just wanted to mention for records that during this grand rounds, we have had the privilege to not only hear from you from point of view of population science, but also we got in Jagat Narula, and Jagat works a lot in the intravascular and CT and looking into the coronary, and of course he has been very intrigued by some of the clinical trials that we have seen in terms of CT coronary atherosclerosis and the progression. And then we also brought in Renu Vermani, who's a pathologist and who looks into the genesis of plaques. And both of them actually brought a very singular message that without there being cholesterol, you cannot have the plaques develop. And so one question I'm going to start, and then maybe I'm going to pivot to others, Ethan and Tudor, to comment upon. How low is low? And if low is better, why not be aggressive even in early childhood?
Yeah, that's a good question. There's some literature about very low might be a distinct phenomenon with its own implications. But I think lower is generally better. There's it's sort of like with blood pressure, and there is yes, you can see in some observational studies a J-shaped phenomenon, but that J-shape meaning higher risk is get to the very low end of the cholesterol distribution or blood pressure distribution. But I think for practical purposes, I think lower is generally better. And that's demonstrated in what you do as cardiologists for your highest risk patients, right? You have a very low LDL treatment goal. And if the patient's high enough risk, you'll start adding therapies on top of statins to get that LDL cholesterol lower and lower and lower. So that may be a naive view, but I think generally lower is better. Now, in terms of treating in childhood, that's a much more complicated question because I think the reason that we focused on familial hypercholesterolemia is to get to the side of the harms, right? We know statins are safe, with very few side effects, and those side effects are extremely rare. However, we do know that years of treatment with statin will raise your risk of diabetes, for example, and so treating a large group of children with high LDL cholesterol with statins is still very controversial, and probably rightly so. We think, just like with all medical treatments, they usually start with the highest risk, right? That's true for cardiology, and that's true for many treatments. Why is that? It's partly because of the clinical trials that I described, but I think it's also that's where things are most cost effective, where you have the greatest health gain for your dollar investment. So we think that the risk of having familial hypercholesterolemia in childhood is high enough, right? You have a very high risk of having an MI before age 30 or 40. That motivates taking the risk of the long-term statin treatment. And certainly, there is a nice study. It's not a direct clinical trial, but there's a study, Lurink et al. In the New England Journal of Medicine that showed long-term treatment of statins with kids not only safe and prevents intermediate outcomes like abnormal carotid IMT, but also compared with what happened to their parents, a much lower risk of ASCVD. So we argue, let's start with where there's less controversy, where you might be able to convince parents that their children should be treated. And it may not be that hard, because a lot of these families, given that it's a genetic disorder, they know a family member who's had an MI or developed heart failure at a young age. And so it won't be hard to convince that family to treat early. Hope that answers your question.
Great. Ethan, your reactions and questions.
Yeah, thank you very much. I mean, really, really interesting and provocative work. I think you're at risk for getting your adult medicine license taken away if you're saying like all the action is with like the kids and the pediatricians. By the time they see you, it's over. Couple of like a few observations and some questions. I really like the cumulative risk exposure, and I think, it makes not only sense in terms of like sort of atherosclerotic cardiovascular disease and sort of I'm thinking like the LDL years are kind of like the pack year equivalent, but we know in like the field of diabetes that there's sort of dysglycemic years and burdens, and people spend years and years and years being dysglycemic and even diabetic before they're detected. I think probably the same thing's going on in hypertension, where people are walking around with their end organs, getting blasted for a while before they get detected or brought down. So I think it's a really interesting epidemiologic, sort of concept, and you've got great data on it. The challenge always is not only demonstrating an association or even a causal, causal relationship between, sort of early LDL burden and bad outcomes, but actually changing that, right? So you're doing this important work of talking to parents and pediatricians, because the big question is people are so adverse to giving kids drugs for long periods of time. And I wondered if, because one of my colleagues, has done some of the pharm epi looking at the higher risk of diabetes and diabetes complications in people on long-term statins. Even though we know if people like who have heart disease, the benefits clearly outweigh the risks. I wonder if there are studies that may address this issue of, can you safely give statins to kids or adolescents with FH, and like their nervous system isn't going to fall apart. They're still going to develop. They're not going to have all of none of their bones or joints will fuse. Because this is a lot of the concern, separate from blanket like pill hesitancy. But it's one thing to look at the trials in middle age and beyond. But I don't know if anyone's been crazy enough to treat like FH people young to demonstrate that it doesn't interfere with sort of early development, separate from the will people prescribe it and take it
Yeah.
issue. Let me
Yeah.
pause there.
Yeah. No, it's great points. And there are long-term studies of kids. I mean, FH kids who are treated with statins. I mean, there are also I didn't add one detail that most of what I'm talking about is what's called heterozygous FH, which is you have one allele, right? And then there are kids who have two alleles. They may have no LDL receptor, and they have sky-high LDL cholesterol. So a lot of these kids are treated. But it's true, we don't have the massive numbers of people treated that you would need for a pharmacoepi study, or really finding those rare events. So I think we're going to need that, and it's another reason I think starting with this group that's super high risk, that the risk-benefit trade-off is probably the benefit-risk trade-off is probably more favorable, that families, if offered the treatment, are likely to take it up and then start to accumulate more numbers in the current small studies, and build that evidence base for safety, hopefully. Yeah.
Thank you.
Great to know your points.
I think it was a fantastic presentation. I wanted to congratulate you for the very thorough and academic way in which you constructed all the models. However, in the current day and age of the medication that we have available, I would say that over the next couple of years, I think that the statins are going to be massively replaced by the PCK19 inhibitors. And the reason I'm saying that is that we've seen a couple of patients that we treated with this medication with unbelievable reduction in cholesterol. And it's not only the power of hammering down the cholesterol, it's just the fact that, for instance, inclisiran, which is produced by Novartis, is a twice-a-year administration.
Yeah.
So if you look in terms of compliance of the patient with medication, we can discuss about studies and treatment, but it still requires that someone takes a pill on a daily basis, and adults are not doing that. There are lots of models published from Canada where it's a very, very perfectly tuned, healthcare system where medication is provided for free by the Canadian government. And 7 out of 10 hypertensives by 1 year don't take the pills anymore from the pharmacy because they don't want to take pills anymore. Well, if you have kids who have a very high risk to develop cardiovascular disease and they have FHA, and you do twice-a-year vaccination, it's very controllable, it's very predictable, and then obviously you see the effect over decades. And I think the research should shift into that direction because it's more predictable for the society. On another end, I still do believe that one single factor alone cannot explain the complexity of the cardiovascular diseases. So cholesterol on one end is a factor, but a major role is played also by diabetes, overweight, insulin resistance, as well as high blood pressure. So this complex interaction between different factors is more effectively addressed by risk factor modification in the community. And I think that study with the barbers from California is very, very telling about people wanting to get risk factor modification into their community. And if this starts at a younger age, it will pay dividends for the decades to follow.
Thank you. Those are great comments, and we are looking at in the renewal application. We did want to look at PCSK9 inhibitors and other novel lipid-lowering therapies. It's true that idea of the cholesterol vaccine that you get once a year, twice a year is really compelling, and certainly when you look when you think about young adults, for example, the idea of taking daily medicines or even going to the doctor may be very unappealing. At the same time, some people just hate needles, and like even if it's more convenient, they will just not go anywhere near a needle. So I think you have to talk to the patients. It can vary, but I agree with you. I think we have to lower the prices of these medicines. It's true for some of the novel diabetes medicines. They're probably better than the current first line. And so we just need to move the prices down so they're more affordable and more people can take them.
Yeah, great.
Yeah.
So I have two questions. I mean, I know we are very close to the hour, but I cannot. So one is from the chat, and a quick reaction to that. Can children function with LDL levels of 20 or 40? Do we have data of safety in children?
We do have some data, and I mentioned there is a study. I could maybe send it. Maybe you could send it out to the group. Really great study published in the New England Journal that looked at. It was a small study in the hundreds, but these were kids who were started on statin and maintained for decades, and no adverse outcomes, and in fact, some very favorable cardiovascular outcomes compared with their parents who also had familial hypercholesterolemia, and other similar small studies. But like I said, these are, in terms of safety, you have to be cautious if you're proposing a big public health program based on a few hundred kids who are treated in these studies. So I think we definitely need more data, because safety data for medicines you're not going to get at that scale. So I appreciate your concern, and I think this is definitely what I'm learning as a researcher. Comes like, oh, I have this great data and it looks like it could be a great benefit, but when you really hit the discussions with the pediatricians and the parents and all these barriers, it's challenging, right? So you have to work with people and meet them where they're willing to meet you and what they're willing to do.
Great. And I would like to come to Dr. Itan Ham. Itan, I want to I think maybe we should invite you for a separate talk. Could you give us a small vision of what's developing for, as the Vice Chancellor for the Population Science and Health here, what you're planning to do, and what are the new things that are emerging where the faculty and everyone can look forward to participating? Any outlines of prevention angle for the health system? How do we participate? What do we do next?
Yeah, so I think now that we're farther along with kind of EPIC as an institution, both in the inpatient settings, but I think more importantly as our outpatient panels accrue, hopefully that will become more helpful for looking at cohorts, and then really being able to use the EMR data to risk stratify people, and both and identify people who are underusing proven effective therapies, or we have a pilot kind of a quality improvement project that Frank Sonnenberg is co-leading to look at hypertension control levels in people with diagnosed hypertension in our Rutgers family medicine and general medicine practice. Well, we want to look in cardiology, nephrology, and maybe endocrine as well. All of this EMR data is pouring into the clinical data and research warehouse. So there are over 8 million EPIC records in that warehouse, and so there's a mechanism for people who want to use that EMR data to do all kinds of research, and there's a process for that. We have a new Learning Health System Scientist Training and Research Center grant that we got from the Federal Agency for our Agency for Healthcare Research and Quality, and so there's going to be both a training angle on that, and we just released an RFA today for learning health system scholars, for people who want to get more training in comparative effectiveness research, dissemination implementation research, as well as we'll in a month or so we'll be releasing an RFA for people who want to do projects to try to improve the care of patients' populations within the health system, so I think those are some ideas. I mean, like I'd love to be able to look at like 10-year ASCVD risk in our adult population and really focus, more globally on kind of global or sort of combined risk rather than, what your hypertension control level is or what your glycemic control level is, but be more holistic and try to, move the needle on the whole population. Even a few points would probably have big benefit, but also interested in, and the other thing I'd say is I'd love to see us look at, identifying populations that are underusing SGLT2s and GLP-1s. So you guys, I think in heart failure, there's much more uptake of that, but still a lot of underuse, and utilization of those is starting to get a little easier and with less prior authorization blockage. But that's another, I think, effective medications that we're not taking full advantage of in all of our populations.
We would certainly love to tap you in when we start designing our clinics and specialty clinics, particularly. I think Dr. Wagneska is interested to start developing the other end of the resistant hypertension clinic, but I think it should be with the proper designing of the hypertension all across the health system from across the continuum. And the last comment, I know that Dr. Moran, we cannot let you go without your comments on hypertension. What would be a design of the next age or the new age hypertension clinics across the health system? What would you dream of? Now you have Dr. Ham and others, having lots of inroads into the EPIC. And how would you design it? And people like Wagneska ready to wanting to ablate. How would you design it?
Yeah. Well, thanks. Yeah, I can wrap up. I mean, before we move on to hypertension, speaking of electronic health records, I mean, there are developed at the Mayo Clinic and Geisinger Health, there are ways of identifying familial hypercholesterolemia using the EHR, but it's more, it's used in adults because they have their cholesterol measured. But too few kids get their cholesterol measured, so you're not likely to be able to use the EHR for that. So you actually have to have an LDL. So turning to hypertension, the ideal hypertension program, well, I know you've already, at Rutgers, you've engaged with the American Medical Association MAP program. I think that's the gold standard of implementing a real primary care-based hypertension control program in the US. A lot of what I've been doing internationally is very similar to that. It's really basic treatment protocols involving team-based care, and having a way of measuring what's going on with your electronic health record. Those are the three main components. There's a lot of cool stuff going on with making care more patient-centered, home monitoring. Maybe the measurements taken at home are actually better and more reliable than those taken in the clinic. So there's a lot of innovative things going on with what seems like the most boring, primary care, common primary condition of hypertension. Yeah, there's a lot of really great innovations going on that you can take advantage of. It sounds like you are. And there's also, there's some people who are, they have secondary cause of hypertension, or they have hypertension that's, it's not about their adherence. You have to make sure, but they're still having high blood pressure despite multiple treatments, medical treatments. And that's where the hypertension clinic comes in, with more advanced diagnostics, more expert management, and choosing the right medicines that might work for people, and if not, non-medical therapies. So yeah, I think there is a place for a hypertension clinic, kind of as Dr. Halm described, kind of at the peak of the pyramid, and that's where, being a tertiary care medical center and cardiology department, that's where you can really help people who otherwise might be. And a lot of hypertension experts, they always tell the story of Franklin Delano Roosevelt, and he's walking around with this sky high blood pressure, and he has a stroke while he's in office, right, in the 1930s. And that was just typical of those days. And certainly we have a lot of great treatments, but less than half of people with hypertension in the US have their blood pressure controlled, which is pretty sad, right? Our neighbors to the north in Canada have gotten the control rate above 60, almost 70%. So we have a long way to go, but we have great treatments and great physicians. So if you focus on it, it'll get better. And that's what was shown in Kaiser and the VA. If you focus on hypertension, you're going to get great outcomes. If you ignore it, you're going to have the same old bad outcomes.
Yeah. Great. With that point, I think we conclude today's session. Thank you very much, Dr. Moran, Dr. Ham, Dr. Vagenescu, for joining in, and we look forward to continued deliberation as we keep on expanding the premise of prevention and health restoration and beyond. Thank you. Thank you all.
Great. Thank you so much for inviting